this week on the BackTable podcast.
And, one of the angles that we explore with our fellows, and one of the things that I think makes our field valuable, is that in every surgical discipline, everywhere, it is widely accepted and demonstrated that the best predictor of how good your patient's outcomes are going to be are how many of those procedures your surgeon does, right? How high volume is your surgeon? How many of these procedures do they do on a regular basis? How used to managing the complications, the potential pitfalls are they? And it's really hard to maintain that kind of volume, not just from a referral basis, but also from the standpoint of being able to keep the lights on and the doors open if you're in private practice. Because if you're going to devote that much time to your surgical stuff, you're not going to be devoting that time to obstetrics. And if you're not devoting that time to obstetric, you lose a huge chunk of the revenue for an outpatient OBGYN practice.
Welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, with, once again, Dr. Amy Park, hosting with us as well today. Amy, how are you?
Great. How are you, Mark?
Good. Good to see you. You just got back from AUGS.
I went to AUGS and then went to DC for ACOG, Clinical Practice Guidelines. So
God,
I'm
love
back.
you guys for doing that work. I mean, it's thankless. It's so important, but it's so important, but it's just work, isn't it?
Oh, I love it. It's like my passion. I love it. I love this job. I actually really like CPG a lot.
So we've got Dr. Marisa Dahlman, good friend of mine, fellows, co-fellows, not like at the same place, but at the same time.
At the same time, yeah.
Same time. Joining us from near Seattle from Virginia Mason, MIGS Fellowship Director out there, and is going to chat with us today about reimbursement in GYN surgery and MIGS.
Such as it is.
Yeah. Well, so good to see you. Thanks for coming on. And as we like to do for our listeners, as we like it for our guests to just give us a little bit of like, how'd you get here? How'd you get interested in this topic? And a little bit of background's always interesting, I think.
I've been at Virginia Mason since I finished my own fellowship. You and I both graduated at the same time, right? So I've been here since graduation. Gosh, 13 years. Virginia Mason has had a small kind of, I guess it was a one-year apprenticeship style pelvic surgery fellowship for a long time. So when I was hired, we turned it into a 2-year fellowship, and we've been accredited by AEGL since 2019. And so now we train 3 fellows at a time. We alternate taking 2 and 1.
Wow.
And one of the things that
Congrats, by the way. It's a lot of work. I was excited when you got your fellowship.
It's my favorite part of what I do. And I think that there's a huge demand for the services that we provide and the surgeries that we do. But one of the things that's always kind of a source of stress for my fellows, as it was for us, was once you're finally done with all your training, what do you do next? And how do you find a job? And how do you make your practice viable? How do you keep yourself going, doing what we want to do? I think most people who go into MIGS, or I guess now, or soon to be complex benign gynecology fellowships, are looking for gynecologic surgical practices without wanting to do obstetrics. But the way that reimbursement is structured for what we do, it's really hard to do that. And I think a lot of people who graduate from these fellowships wind up taking jobs where they have to do obstetrics for at least a little while in the hopes that they can build themselves a referral base that will sustain themselves. And so one of my fellows last year started looking into kind of trends in reimbursement for gynecologic surgical procedures. Every year, there's a current opinion issue that focuses on topics in minimally invasive gynecologic surgery. And my fellow, Dr. Michelle Den-Adel, proposed a topic looking at trends in this and how this might be impacting the state of the field. And so we had a review published last year, but it sort of got all of us interested in how is it that what we do is valued or not, how reimbursement follows that value or not, and what that means for the future of the field, both for people who are graduating from fellowship, but also people who are looking into applying for fellowships, and how the reimbursement for that is going to impact the field as it grows.
No, that's great. And we can have a little bit of nostalgia here for a second, because thinking about when you and I, we're not that old. I mean, come on, we've, 13 years now, but it was very different than it is now. And I love that the fellows graduating now don't have to deal with what we dealt with the same way. I think I remember when I was looking for a job, and John Delancey of Michigan, who's a Urogyne, was like, "Oh, you sound like us 20 years ago," and like it was coming. And I'm really proud and pleased to see where it's gone, because it does help me start to believe that people genuinely care about this stuff the way that those of us that do it care. When you first went out there, were you doing obstetrics?
I wasn't. And that was one of the reasons this job had such an appeal for me. It was when I was hired at Virginia Mason, there was no obstetrics in the hospital. They had closed their obstetric service line years before. And so all of the gynecologists on staff were just gynecologists, and they did mostly operative stuff. Although there was sort of this sense when I joined that you pay your dues by doing annuals for a few years, and that's how you build your referral base. And what was interesting is that we were graduating fellows and sending them out into the world and telling them, now you're a surgical subspecialist. And so you should be seeing surgical consults, and you should not be seeing primary care. And it took a couple of years of me and my one partner at the time, who was a graduate of this fellowship program, to say, if that's what we're telling our fellows, we should afford that to the members of our faculty as well. But it sort of got at the, like, so if you're not seeing annual exams and hormone replacement and contraception, then how are you bringing in revenue for the institution? And the answer is you need surgical referrals, right?
No, I lived through that. I did OB for a few years, and it was like a couple call shifts here and there. It wasn't like I had an OB practice, but it was doing L&D call to support my practice. There was no sort of like desire to help build my practice through referrals, mind you, right? It was just,
right.
I was the clerkship director for 6 years. There's all these things that were given to help me sort of like, oh, this is going to be hard. And at the time, like, oh, that's nice. Thank you for giving me all these other opportunities that are not GYN surgery, so I can have, RVU buy downs or other RVU producing procedures that are not GYN. But then after a few years, I was like, wait, none of this is helping me build a practice. All of these things are delaying me. And so first it was giving up OB, and then it was sort of putting my foot down. It was about 5+ years out, and I was like, I won't name names, but there's, it's like, oh, well, we can't have you stop doing general GYN. You won't be able to produce RVUs. And I said, if I don't stop it, I'll never be able to do what I'm doing, and I'm going to leave. And my chair's like, all right, you control your templates. And the minute I did that, I became like the busiest benign GYN surgeon, like overnight. It was just so fast because it allowed me to do what we trained to do. And yeah, I love that's your message, and I love that's what y'all are talking about, because I think there's this idea that, oh, you can't do it. I mean, this is what we do this work, and everything else is just really keeping you from working at the top of your degree, and nothing is more frustrating, or, it can certainly cause burnout if you're not doing the work that you're trained to do, that you're interested in doing and curious about. So that's awesome.
Not to have the autonomy to make that decision yourself. It's the biggest contributors to burnout, right? Is lack of autonomy, lack of control of what you do.
Yeah, and I remember that too. I mean, I remember Suketu Mansuria and Ted Lee. Like, Suketu had to do OB for a couple years. This was in 2004 or something. And then, people just didn't understand it as a field, because the Venn diagram for MIGS and MFM just is like, it overlaps like this. And people didn't understand the whole idea of it. And I think even in MIGS, it's a little bit of a identity crisis, because changing your name from MIGS to complex benign gynecologic surgery?
Complex benign gynecology is, I think. They're going to officially announce it to us at AAGL coming up. But yeah, I think the new acronym is CBG.
Yeah, I mean, I remember that, like, a lot of folks, like the Sokals, were saying, like, we're not an approach. There's the specialties that are not an approach. It has to be based in pathology, and that's what the Urogynes were telling us. It has to be based
in a disease process.
It was Delancey's work and studying, proving that Urogyne was an actual thing, and we knew it with fibroids, endometriosis, chronic pelvic pain, that was enough. Like, you didn't need more than that to be a subspecialty. But it took us transitioning, even AGL, the name, and MIGS, the name, like Amy said. I think it delayed and, in a sense, some ways devalued, not intentionally, but it means, I do laparoscopy too. I'm like,
right,
no,
it's a fellowship in toys.
Yeah, no, I think that was something that made it harder for folks to truly understand Because people say, oh, I do minimally invasive surgery too. I'm like,
I wonder how the focus practice examination is going to play into that, because when Urogyn started with a focus practice, they limited the number of years that people who hadn't done a fellowship could take the exam. And they've not shown any inclination to do that with the focus practice for minimally invasive.
Right.
No, it's open to pretty much anybody. And there's a lot of people around here who are marketing themselves as minimally invasive gynecologic surgical specialists with this focus practice who've never done any additional training over and beyond a residency.
Oh, really?
Oh, yeah. All over the place.
There's REI folks. I mean, there's more people doing IVF that are not REI trained than are in this country. I think there are plenty of people that still call themselves urogynecologists that are neither fellowship trained nor boarded. I mean, those people graduate out. But I think the biggest hurdle for the MIGS focused practice is going to be the volume. Like, I don't think most people who do obstetrics or for whom obstetrics make up a large bulk of their practice can hit the volume numbers unless they've changed. They were reasonably high and wide in a way that if you weren't doing a lot of GYN, it was hard to sit for that exam, I thought.
Yeah, I don't remember what the numbers are. I did it. They told all of us who were program directors that we should take the exam. So I did, and my associates did. And, it was interesting how little of the exam actually was focused on actual...
Yeah, like back pain and like random,
clotting
agreed.
Cascade, numbers, things that I haven't thought about since probably step 3. Yeah, there were some interesting parasite questions on my exam. Anyway, one of the things I'm going to be interested to see, I don't know if you guys know this, but through this year, there was a huge blow up and I think this happened to a bunch of fields, but there was a huge to-do when fellowship applications were released, because we got maybe half as many applications this year as have been traditionally. So this year, there were actually only 2 more applicants than there were available spots in the country.
What?
And for MIGS.
The factors that are driving candidates from not pursuing fellowship is what you're driving at, the reimbursement. And then also it's just like what's happening for female urology and PAG. You have to train more for less pay.
Yes.
And you still have to be in general call. And
For sure.
Not that you have to be in general call, but if you look at the lifestyle and everything else, it has to be a calling in a way. And I think that people are more interested in REI, for example, for different reasons. But I think that is the debt load, the delay in salary, and it's like a crisis. I mean, is this also affecting primary care?
The new caps on federal loans.
Yeah,
This is
that's
part of
going
the
to be
big
a disaster.
$50K a
I wouldn't-
year. I mean,
I
forget
wouldn't have been able to go to
undergrad.
medical school with those caps in place.
Nobody can.
No,
Yeah.
absolutely
It's crazy.
not.
It's
Yeah.
crazy.
I mean,
So
the rich
I think all
can,
of that
but-
stuff, the loans, people with $350,000, and I guess one of my fellows was telling me that 2 med students in New York got married and both had $500,000 of debt between college and med school. And instead of a marriage, the dean joked that it was 2 huge debts that were merging.
Absolutely. No, my spouse is a physician. We got married in medical school and we graduated with, the number was stupid. It didn't mean anything because it was more money than,
double.
yeah.
I mean, med school right now, where I am, the tuition over the it's been less than 20 years, it's tripled.
My God.
And I asked, what are we getting for this money? I've asked people, what does it cost to educate a medical student? Honestly, because most academic medical centers, the faculty pay themselves to teach. You need an anatomy professor for 6 weeks, a pathology professor for 6 weeks. Well, this is what the NYU $1 billion endowment donor said. He's like, I'll give the money, but we got to lean this up a little bit. What are we getting here for this money? If I'm going to give it to you, what am I spending the money on? And the answer is not that much. The administrative costs are there. It's not, nothing. Do we need to fund an entire pathology department? Not pathology, but
Right.
But anatomy and physiology, those, they can handle themselves and let us borrow a teacher for a few weeks.
Academic biomedical sciences rather as opposed to clinical medicine.
But we have an educational college where half the time the faculty are in a sense paying themselves to teach.
The whole question of like pursuing fellowship and deferring attending life for 2 to 3 years, it's a complex calculation of like deferring more of your attending life and the paying off your loans and lifestyle and like what does the future hold? And there's a lot of uncertainty. The bottom line is that we have workforce issues across all the subspecialties and for specialists. So I don't know. It's a complex quandary. I don't know what the answer is.
Was that true across specialties though? Like general surgery or any other, were there other specialties that were seeing a similar drop, or was it just us?
I don't know. I anecdotally sort of passing people in the doctor's lounge, I guess, to a degree, but the number of graduates from the general surgery program at my institution, I think the same number are applying for fellowship. It's not all of them. I mean, I think it's probably going to hit every specialty to a degree. It comes up every year at AAGL when we talk about at the program directors meetings, and they talk about a 2-year fellowship, and there's some push to make it a 3-year fellowship to be more in line with oncology, and I feel, and one of the things that they love to bring up has always been the match rate, right? That there is, a 17-18% match rate among applicants to this fellowship. There is great demand. We're turning out great candidates. We're, people with wonderful training. If the percentages are no longer indicating that, if it is a trend and not just a this year thing, I think that's one of the reasons we have to think about it. It's hard to ask people to give up to basically take a 60% pay cut to work as a fellow for a couple of years, and then to graduate and realize you're making less money than you would have if you were going out as a generalist straight out of residency.
Forgetting the compound interest.
It's hard to
and all
sell
those
that,
things.
right?
So wait, there were 5 to 6 applicants per spot before?
At its peak, yes.
And now it's half to 1. Or no, it's 1 to 1.
It's 1 to 1 now, or it was this year. In previous years, I think we've been seeing about 2 to 1, 3 to 1, but this year it was stark. The drop in the number of applicants. As soon as the applications were released this year, the program director WhatsApp chat blew up as everybody saying, is it just us or is it everybody? And it became very clear very quickly that it was everybody. There are good programs that went unmatched this year.
Well, I think also the other thing is, remember, everything is cyclical and the pendulum does swing. So, when I was coming out, anesthesia was coming back from a lull. Now anesthesia is hot. Like there's not enough anesthesiologists and people have to go to private equity groups because there's not enough hospital-based ones. I heard Hopkins went to private equity anesthesiology group. I don't know if they're still doing that, but the pendulum does swing for some of these specialties. I don't know. I think it's a very complex calculation of what the reimbursement is, what the lifestyle is, what is the call schedule. Like I heard colorectal was very competitive this year. And they, there was a pretty high unmatched rate. So but I don't know. Is colorectal call better than gen surg call? I think it probably is.
Probably.
I don't know.
I think it also depends on where you go, right? Like there are places where they're in the pool to cover all the general stuff too, just because
That's true.
There's
And also there's a lot coming with like AI. Like you think about pathology and radiology. I've heard both arguments that it's going to be obsolete versus being actually far more valuable to have radiologists when AI is reading 10 times or 100 times as many scans.
People have been saying that about AI for a long time with radiology, though, and they're making they're making a lot of money. But yeah, I don't know. I don't know what the answer is, but I do think that what you're saying is kind of that this also gets to the heart of the whole matching and setting up a practice and your shingle, and then those people who are opting out of the hospital-based practices and setting out their own shingle for cash-only situations. And I think they're just too. We're opting out of this system, and it's crazy because I think a lot of people are seeing them because the wait lists are so long. I don't know how long it takes to get in, but I know our MIGS team is booking well into 2026.
Yeah, so are we.
Yeah. So everybody is booking out.
Let's talk about why that is. Everybody else's wait times are 2 weeks. Marisa, tell us, what is it about GYN surgery that there's not enough of us and no one cares? Or what's the issue?
Yeah, I think that there is. So when I first started in practice here, we would get referrals mostly from within kind of the primary care group affiliated with the hospital, which makes sense. It was sort of our automatic referral base. Then we sort of, my hospital was interested in sending out feelers and having us go and meet with private practices and smaller groups in the area. It's like, yes, we can see your patients for all of the following things. Fine. We were, for a long time, one of the major teaching sites for the University of Washington residency program. There's a lot of residency program graduates who would stay in the area. And what they started doing is saying, all right, well, this is a patient who's got big fibroids. This is a patient who's got complex chronic pelvic pain. We're just going to send them there, right? And so I think that's happened more and more. And as, some of it's just like if you're in the same place for long enough, then you kind of build your reputation as if you've got bad endo or complex chronic pain, send them there because they like those, right? It's like, yes, all of the complex chronic pelvic pain, where you know the not the details, but you know the outline of the story, just walking in the room. And you walk people through it. And so some of it is being around long enough to be able to generate that kind of volume. But I think also there are more and more generalist OBGYN practices where they don't have maybe not the interest, but I think also not the bandwidth to do that kind of thing, especially given the fact that reimbursement for it is not great. And, one of the angles that we explore with our fellows, and one of the things that I think makes our field valuable, is that in every surgical discipline, everywhere, it is widely accepted and demonstrated that the best predictor of how good your patient's outcomes are going to be are how many of those procedures your surgeon does, right? How high volume is your surgeon? How many of these procedures do they do on a regular basis? How used to managing the complications, the potential pitfalls are they? And it's really hard to maintain that kind of volume, not just from a referral basis, but also from the standpoint of being able to keep the lights on and the doors open if you're in private practice. Because if you're going to devote that much time to your surgical stuff, you're not going to be devoting that time to obstetrics. And if you're not devoting that time to obstetric, you lose a huge chunk of the revenue for an outpatient OBGYN practice. So it's hard for people who are in generalist practice to devote enough time to growing a surgical practice because
besides
the
patient
reimbursement is
population,
poor.
You can't have ORs available to you if you don't use them on a regular basis.
Right.
As a former OR director, right? I think these are the kinds of things that you're not use your time. It's going to someone who will. And so if you got one day a month in the OR and your partner's already scheduled 3 cases and you're sharing that day with 4 other people, it's just hard to be a surgeon. And I think that's one of the things that we as OBGYNs, we talk about it a lot in the show. Let's decide, let's be honest, who are we? Because no other surgeons dabble in surgery. Okay? No other specialties spend 80 or 70% of the time of your training not training you to operate. So what would we like to happen? We can complain, but if we don't change something about it, we're going to be telling ourselves a story for all of eternity.
And the problem, then as far as reimbursement is concerned, there is certainly the cost to the individual surgeon, but there's also the cost to the field that goes along with that. So one of my partners is on the committee at our hospital that looks at robotic time and distribution and kind of the steering committee for the use of the robot. And it was brought up with no malice and complete bald-faced idealism by one of the non-gynecologic surgeons. Well, maybe we should assign robot time based on RVU value attached to the surgeries done. And my partner dug in her heels and said, this is a terrible idea because, as your podcast has explored before, RVU valuation is a pretty poor metric for the work and the value of the work that is done.
Can I just interrupt here and just say, to take devil's advocate, not devil's advocate, but just also the natural sequelae of cases going to high volume surgeons is who's going to take all the call for the ectopics and the ovarian torsions and do the BSOs and the laparoscopic tubal ligations and self-injectomies. Certainly there's not enough MIGS surgeons to take that for a big hospital system. You know what I'm saying? So it's we need to preserve skills for people. And also, ACOG represents all of us. And obviously, there's other societies that are on this. But as Mark has alluded to, without the support of ACOG to affect these changes is pretty hard to get some space at the table to discuss these issues. And, out of 60,000 OBGYNs, how many MIGS surgeons are there in the country? Like 500?
I think it's more, but not many more.
Not much more from the last I've heard.
I mean, that's not enough. That's not enough of a workforce to take care of like all of the ectopics and all of the things that come in like on call or DNCs or whatever. Right?
I would argue it's not enough of a workforce to deal with all the stage 4 endo and complex fibroids that are out there. There's still places in this country where the only hysterectomy somebody can get for big fibroids is a vertical midline laparotomy.
Oh, I think there's a lot of places like that. But I also think about, our training in general. Barb Levy at dinner used to always say, like, we just need GYNs. Like, there's no reason why a GYN can't just do GYN cancer surgery and urogyn and complex GYN if they were doing it all. If they spent 6 or 7 years just, if you took someone, took 7 years and said, on your MIGS ago, and just only did 7 years of training for surgery, could you do all those cases? I mean, probably.
For surgical cases, yeah.
Again, we know the clinic management is a huge part of it, and there's a whole lot more to it than that. But I think, yeah, you're sort of between a rock and a hard place. I mean, Amy's absolutely right. My life is much better sharing call with my generalist colleagues. I mean, it would be untenable, I think, for many of us in our situations to only be on call for the ERs if no one else operated. And I also love operating with my generalist partners, in certain cases. So there's a range for it, but it doesn't feel like there's a strategic approach to it, I guess is what I'm trying to say. Maybe I haven't seen it. I'm sure folks are working on it. But the other thing is hospitals will, so we have the, dollars per RVU, there are RVUs attached to a procedure, but there's also each hospital decides what the dollars per RVU is.
What the dollars per RVU are. And it's different from field to field, which I didn't even realize until I was well out in practice.
Yeah, but then each hospital can decide to change it. So anyway.
Yeah, I agree with you about this, what people are saying about, we see this happening in my old job. Like, women's health is not part of the strategic plan. So in terms of OR and allocation and block allocation and resources, it's not going to women's health. So how do we prevent that from happening? I mean, we have people like Mark dealing with operations and being a voice at the table, but it's like a stark and bleak landscape. Let's be honest.
And my boss is a GYN oncologist. I mean, we have some pretty good representation in our hospital leadership, but that's not always the case. And I'll, thank you, Amy, and I'll use this opportunity to get on my soapbox and say, get yourself a seat at the table. We have to advocate for ourselves, not for our own personal benefit, but our patients benefit when they're not having to wait 6 months for surgery or 3 months to get into clinic. When we advocate for ourselves as clinicians, our patients benefit.
I think in a lot of systems, including mine, some of that is limited by the reimbursement, by the money we bring in the door. So I'm an employed physician. I belong to a healthcare organization, right? And so seats at the leadership table and decisions about who gets a nurse, who gets a PA, who gets clinic space, who gets another OR, who gets access to the robot, a lot of that is tied to how much revenue we bring into the institution. And if we're capped by 58662, fulguration or excision of ovarian lesions, it's really hard to drive that up, And it means that we're limited in our access to seats at the table to try and make those changes and try and support our patients. We are fighting in a practice of, we are now 4 MIGS surgeons, 2 oncologists, 3 fellows, 4 nurse practitioners. We have 3 medical assistants. We've been fighting for a 4th one. It's real hard to get them to approve it. We don't generate enough revenue for them to hire somebody.
I think part of it is understanding, where your value is. And I've been trying to figure out how to put this on paper, but, if you don't have someone who's high volume, what are you spending in OR time in cases that are going longer? What are you spending in hospital beds? We're always full, right? So same day surgeries is extremely valuable to hospitals when they're full. So you don't have 2 days in the hospital for a laparotomy. You're not getting paid more for those days that they're there. They're just sitting there as a global period. So it's not necessarily even what those patients are coming. They need care. What are we doing to be as efficient, as high quality, low rates of readmission, low rates of complications, those things which the hospital will absorb. If we're not high reimbursement, we're high value compared to a lot of the other docs out there that haven't had either this training or this volume in their practice. And not everybody has to be a fellowship trained surgeon, but if you're not committed to doing this work, outcomes will be different.
Will be different. Yeah.
The thing that I find interesting is that, like, talking to different people around the country, certain systems have a totally like what you're saying about RVU, which procedures bring higher RVU and margins. And then, it's interesting to hear Mark's hat as like hearing what the margin is on orthopedic surgery, because that's usually on the strategic plan. But then they're hearing that their implants are so expensive, their margin is actually not that great. It's fascinating to me. And then, but then you talk about different health systems, and I don't know what the approach is called, but it's like the approach of like, okay, like historically, GYN has had a 99% utilization time. And then other systems will say, okay, well, in some systems they'll say, okay, well, you should get, you're booking out like 3 or 6 months, and you're utilizing 80 to 90% of the time, or whatever it is, the metric. Then you are in line for earning more time. Then you have other systems who are like, nope, you're capped. It's just a different approach.
Then here's a plug for physician leadership in healthcare. When you have physicians running health systems, I think it's like the top 12 of the top 15, something like that, and don't quote me on those numbers, but something like that, of the top hospital systems in the country run by physicians. When you have private equity, which Amy mentioned, right, there is no GYN, ortho, it doesn't matter to them. It is margins, it is dollars. It is not an infinite game when you have private equity in healthcare. It is a cash out at some finite point in the future. And so, I think understanding the hospital systems you work for, understanding who your partners are going to be and the why of your organization, I think I'm lucky where I work for a number of reasons, but like someone's busy, like give them more time, right? We have to balance it. But I don't hear about, well, it's ortho and the margins. It's like, are you busy? How far are you booking? And let's fill it in, because I think if your mission is caring for the people and your mission is taking care of this population of patients, it's on the leaders to then figure out how to pay for it, as opposed to our mission is to make money. That's the system. Make no money in a mission. I get that. But like, what is the why of your organization? And that matters.
Absolutely. I do feel fortunate because I work at a physician-led organization, and that imbues the culture. And we have very collegial relationships with across the surgical subspecialties and, all specialties. I think it's very cordial and high professional courtesy, but it's sad to hear that certain places are not like that. And it just feels like we're here. It's like I said, it's not like other places, but when you're scrambling over this fixed pie mentality, it makes it tough when that's what you feel like. You're not getting allocated the resources. And you know what? Medical assistants are cheap. I cannot believe what you just said. Nurses are expensive, but MAs are not.
Even just finding to get more than one person to sit at the desk to get people checked in has been insane.
But that's something like, I'd want to see what the ROI on that is, right? Like if you have patients waiting and not getting, roomed and not being able to see enough patients, like you can do that math and see how much they're making per patient. Like someone's got those numbers, and maybe they've just decided that like doctors seeing patients isn't profitable, then maybe don't be in the healthcare business. But I do think that I spend a lot of my day saying no. Listen, there's a lot of people who aren't OBGYNs who probably won't hear this show who would roll their eyes at hearing me say this, because I say no all the time. But I really feel like my job is getting to yes. Like, okay, you want this thing, that ain't gonna fly. Okay, that's not gonna get past my senior team here. The people writing the checks are gonna laugh at us. So let me help you tell that story in a way that is gonna actually make sense. And faster OR times, that don't work. Knowing goes faster. Sorry, like shave 6 minutes off this case. I don't care. right? There's ways to and if we can help people, so I would say finding partners and colleagues in your institution who understand this stuff, if it's not like your thing, find the finance folks, find the women in the finance department who are help you build that business plan, because they're like, oh, it took me 6 months to get my sister in. So yes, what can I do to help? Right? It is I've had that. I've had advocates and allies along the way. Everything I've had in this job is because people help me along, right? Find those people in your system who can help you get there.
Well, so what's happened to us, when I joined my organization, it was a small physician-led organization, and there was that culture of we're here primarily to take care of patients and, the rest of it. But the problem is that when the rest of it is not fiscally sustainable, what winds up happening is you are absorbed by a larger organization. And so my organization was absorbed. They would like to say it merged, but really it was absorbed by one of the very large Catholic health systems that is so decentralized that finding where the top is and who to talk to about things has become very difficult. And I think this is a common thing. There's the private equity where they don't care at all about the human part. It really is just about the bottom line. But for large conglomerate organizations, small parts of that don't gain a lot of traction when you're trying to make organizational change.
And Common Spirit's the biggest health system in the country. Is that right?
Might be.
Is it for-profit or nonprofit? Do you know?
It's nonprofit.
Not-for-profit. Okay.
It's nonprofit.
Not that
Catholic health initiatives.
Yeah, that's right. Yeah. I think one of our former hospital leaders is now their chief of quality or something. I can't remember. I saw him at Vizzy, but that's the first time I'd heard that name.
I think it's a kind of a stark future ahead of us with the Medicare and Medicaid upcoming cuts. I worry, does that mean for our health systems? The margins are so slim. I mean, we're batting down the hatches. I think people are going to be looking for efficiencies, and how that plays out is TBD. I don't want to sound stark.
Well, no, it's the
coming.
reality.
Yeah.
It's here. There is no, this could happen, right? They are telling us the money's going to be less for most of what we do. Got to come from somewhere, right? And so if it's stuff or people, I'd prefer to save it with stuff. If it's efficiency over, RIF is a term I hadn't heard until I became.
Oh, I know about RIFs. Yeah.
An administrator, right?
Reduction in force. Yep.
Yeah. So then it's like, then every day I get out of bed, I'm like, okay, how can I save money on stuff? How can we be more efficient? How can we be more lean without, getting rid of people? Because people are what make this thing work, right? That's the part that I'm pretty confident that matters most to what we do. But Marisa, what do you think? We've been painting a pretty gloomy picture here, but
it feels
with your work,
gloomy, right?
where's the way? Where's the path?
Where's the way? I don't know. I mean, I don't know. Is the way to dismantle the American healthcare system and rebuild it from the ground up? Is there a way to fix it? And the way that it's structured, the way that reimbursement is so central to this, the way that the companies that contract with people to pay for their health care are for-profit entities more beholden to their shareholders than their customers.
Yes.
Is there? I mean,
yeah, but I think that's you say fix it. I mean that implies that it's broken, and I always argue that the system isn't broken. It's doing exactly what it was designed to do.
What it was designed to do,
which is make money off people's ills,
suffering,
and that's we don't have a healthcare system. We have an illness care system. I think at the end of the day, enough hands get in the pot will crack. Unless we have the maturity and foresight to turn this ship around and say, you know what, this is a bad path. Let's change things. But there's just too many people who make a living off this stuff that have nothing to do with the patient-physician relationship. And at some point, the federal government, the biggest check writers of all, will say, hey guys, and they're starting to now, to Amy's point, we're done. We're writing smaller checks. You guys figured out. At the end of the day, that's how change happens, right? We just tell them that y'all took advantage of this system and someone's got to go. Something's got to go here. We do it. We spend a lot of money on healthcare, period. Look internationally, we are the worst at this job. Cost of care, we're the worst. You can argue that we're the best, but in healthcare, but numbers don't show that. So I don't know. It's being done elsewhere.
Yeah, I don't know what the answer is. I know for us, I'm always trying to focus our mission, our strategy, our vision so that it aligns. And like most of the time, what's best for the patient and the physicians and the team align. But in like a more global scale, in terms of like these efficiencies, I don't know what the answer is. It's like you need support. We all need support. I do think that the scale of like making money and what not is not making money, I mean, I think that needs to be carefully examined because I did look at our net charges. I'm not talking about gross. Like this is like what we actually are bringing in like cash. And I just added up everything on the back of the envelope calculation and just made up all these numbers that were like exorbitantly high for 5 offices and all of our salaries and all of our nurses and all of our front desk staff that we are definitely sharing, but I just made it up like we are the solo ones carrying it in Eurogun. And I was like, there's no way we are bringing in this. We're not profitable. But it's just like how profitable is the curiosity, and it's a little opaque. Talking to my old group, it's like looking at the numbers and the FTE allocated and all of that other stuff. It's like the numbers that they pull can be erroneous sometimes.
I don't even know like where one begins with that. Like every year at AGL, there'll be papers published that are looking at things like cost, trying to nail down cost. And remember, good luck. Like nobody knows how much any of this costs. And if you're, is it how much you spend to get the equipment in the room, which is going to depend on what the negotiation between the device company or the supply company and the hospital system is. Is it, the same procedure done not just for people with different insurance plans, but different plans within the same company can be totally different. How does one measure cost in a system as messy as ours? Like, we have no idea. And like, how much do we bring in? Is it how much we bill, how much we expect to get paid, how much we actually collect, which are all different numbers? Like, how do we even know?
Well, it's so true. It's all negotiable. Like what Mark was saying about the reimbursement is negotiated even within the hospital, what's assigned, and that's per specialty and location. And if you're an ASC versus a facility, but also if you are, we have a pretty large group purchasing organization and it's supposed to negotiate on all of the supplies. And that's why you see these large single specialty organization. Like when I was in DC, the Capital Women's Care, it was like all these private groups banding together so they could get like chucks and speculum and stuff like that, like at contracted rates. And insurance companies, I mean, my mom was a solo private practice OBGYN. And, at one point, like insurance companies dropped her because she wasn't worth it. Because in the old days, you could just charge whatever you wanted and they would be like, okay, we'll pay you. And now it's like all explanation of benefits. And you see how much the pediatrician is getting, that's the most of our healthcare is like pediatrician bills, right? So you see, it's like they charged $300 some and they got like 80.
Yeah.
I mean, that's like...
And I'm responsible for $3.27 of that, right?
Right. It's all based on CMS's, with the RUC, right? When they decided whatever is worth, and not just our work, but the facility fees, right? And what, how many booties each procedure,
No, but it's not even the RUC. That's the RVUs, but it's the negotiated rate that insurance companies pay for like X, Y, and Z too, because RVUs is the same.
It's all based on CMS is like the bottom of that. And so but yes, you're right. It is all negotiated. It is moving targets, right? It is always changing.
Makes it make a lot of sense why, especially if you are in a specialty where the reimbursement for your work seems disproportionate, that you will say, and I will accept cash. And you are more than welcome to deal with your insurance company on your own. But I will be paid in cash, thank you.
And I believe in the power of the market. And if we only have as many, if we don't have a ton of applicants for this specialty, maybe that's telling us something. And if we don't have enough people to do the surgery in 10 years, something will probably change, right? I think those are the kinds of things that when you don't have it, it's easy to say when you have it, it seems like a lot of money, I'm not going to pay you. But if there's nobody doing it, all of a sudden...
Then its value becomes very apparent.
Right, all the locums phone calls we get.
Yeah. Well, to be honest, though, I mean, I know we're complaining about gynecologic surgery in particular, but honestly, it's rough for OB. Like, there's all these maternity deserts. It's viewed as a loss leader. It's very difficult to staff these. It's like an ICU, like the labor and delivery units. Like, it's what is a ratio 1 to 2, 1 nurse to 2 patients.
Yeah, no, it has to be staffed like an ICU.
Yeah, it's not easy. And then you have one malpractice suit that just like wipes out your margin for the year. I mean, that's crazy. I mean, that's why I just saw that happen in Pittsburgh. That's where I trained. All of these surrounding hospitals just closed their OB units, and then everybody had to travel in. And if you're at like even a titch, like high risk, they get transferred in.
You get referred. Yeah.
Yeah, and I saw that triage unit. It was like 10 rooms and then 20 labor suite rooms, and then it became like 25 or 30 labor suite rooms. It's gotten crazy busy, and antepartum is crazy. I mean, it's like people are like, oh, well, I'm just going to offload it to the tertiary care center. I mean, you said Kentucky's like that, right?
Well, in terms of the desert, in terms of the care desert, or...
Yeah, and the transfers in and the acuity of the patients.
Yeah, I mean, Eastern Kentucky is like the highest acuity of patients in the lowest resourced communities. I mean, I think 6 of the bottom 10 counties in terms of life expectancy for women are in Appalachia. So like they have no access to preventative care. And then they come into their local Band-Aid dispensary as sick as anyone you've ever seen. And so like they're all calling UK going, what do we do? Can you send them? And we're like, we try to turn away as few, and we turn away almost nobody. It's amazing what our transfer center does. But the volume is crazy. And with the new bill, they're projecting as many as 33 or 34 hospitals in Kentucky will close, primarily in Eastern Kentucky. Like I think Louisiana was 1 at 35. Kentucky, I want to say, was 2nd at 34 or 33. Like, hospitals, not like practices.
Wow. Practices, yeah.
Will
like
close.
Entire hospitals will disappear.
And so where are they going to go? They're going to come
tertiary
see us,
care.
right? Yeah, that's
Academic
it, right?
tertiary
So
care,
we're doing everything. And so, yeah, it's you look at the trends and go, we need a plan here. We need a strategy. And when you don't have one, it'll fail. And that's just, and we'll pick up the pieces and rebuild it one way or another. I mean, whether I have confidence in our ability to make the right decision today, I have no doubt in our ability to fix it when it breaks. I mean, we have so many good, smart people who care. And that's the other thing I say every day is we got a great job where everybody who comes to work with us in any hospital, right? They're trained. They've chosen a field where they want to care about people, and they've already jumped through enough hoops that we can say for the most part they work hard, right? Like we have those people in every corner of our hospital system. We have to figure out how to give them a job they want to come back to every day. But it's hard work. Healthcare is hard work, and it's becoming tougher, no doubt.
Well, I have to give you guys credit because I always tell this story about like the power of the MIGS surgeon or complex benign gynecology, whatever you guys are called. But I remember one day my fellow, he was becoming our fellow. He was a resident. There was somebody on the resident service, and she was on dialysis, and she had no legs. She like had bilateral AKAs, and she ended up having like bilateral TOAs or something. Speaking of our previous episode on TOAs, and she was going to get opened because she wasn't really responding. And then Nick asked Jim Robinson to take this patient on, and I walked in on this case, and it was like a hot mess. And they did it all laparoscopically, and she did fine. And then you know what? She did not walk out of there, but she was wheeled out there. She was fine.
With a big old smile on her face and tiny little
big old
incisions.
smile on her face and tiny little incisions.
Like I was like, oh my God, you did it. You did it. That's amazing. And I was like, that is where you really, I mean, who knows what an open surgery would have done to this patient? She would have been in the house for a lot longer.
Oh yeah, wound vacs and everything. I mean, it would have been.
Oh yeah,
Yeah,
it was crazy. And I was like, I was like, oh my God, that is such a service. It basically saved
But
this lady's
I think that's
life.
the conversation to have at a hospital, right? Like, what do we bring? And it's not just MIGS or whatever. Again, I've got generalist partners who are really great surgeons who have made a commitment to make GYN surgery part of the practice. They operate a lot. They always, like when they need help, they call me or a colleague and get better. And they don't call very often, but like the department and the hospital have committed to this is important. Women's GYN surgery is important, and we're going to support it. And there's a lot of different ways to do it. But yeah, it is a challenge when the reimbursement varies based on the patient population. And when you're a specialty where the patient population is women, not just like people who need knees or who have cancer, but actually just like all women.
People who need colonoscopies.
Yeah. And so I think there are hospitals out there that are doing it well, that have made a commitment to women's health and are doing well. And those are the models. We're lucky we know lots of people, but go around AGL and ask what people are doing and see how. Somebody called me once from their practice in another state and were complaining about, no one cares. I said, well, here's what we do. I've got a chair that does this, this, and this. And he went back to his chair and told him everything and called me back and said, my chair said, okay, and gave me a raise, and we hired another partner. It was like, just hearing that other people are doing it this way and doing it better, sometimes that's the stories we have to tell our leadership to say, no, like it can work and here's how. And we're very lucky that we've got all these friends around the country who are doing such interesting things, like, for example, Dr. Marisa Dahlman, and who come on the show and share that with people, because I think there's a lot of different ways to do it, but it is working in places. And how do we, get that message out there?
Hope so. I think it's one of the valuable things about heading into our conference in the next couple of weeks is it's helpful to talk to people in different systems and from different parts of the country to see what are the challenges that all of us are facing and what are the things that some of us have figured out and some of us haven't. It's one of the reasons I look forward to our meeting every year as a chance to kind of check in with people from all over and not just within my tiny little bubble.
I'm excited, and I get to, that's a plug, but this will be on after people leave. But we're doing a postgrad course. I was invited to give. We have a postgrad course on billing, and Nicole Monarts is the lead of that, and John Hathaway and myself and others are going to be talking about this kind of stuff, right? How do you get credit for the work you're doing, and just making sure that every last RVU, every last bit of work, not more than you've done, but to get credit for what you've done is important.
For what we've actually
all
done.
those things help us justify our existence, and that to me is advocacy for your patients.
The value that we bring.
By the way, I saw something about the OB global getting broken
They're getting
up.
rid of the global.
Is that going to be better for us? I have no idea. I'm just asking, like from a place of curiosity.
I don't know that it'll impact those of us who don't do obstetrics, but I think it's wonderful for the people who do.
It depends. I think that, historically you did all the OB work for a patient, you deliver them, and that was just the easiest way to do it. I thought it was being done state by state, though. The last I read, it was states were like deciding whether to do it for their state Medicaid patient population. It depends. It's going to become more common, but they'll come into delivery, but then someone else across town did their their prenatal care.
All of their prenatal care. Yeah.
OB care is clearly much more fractured than it was when our parents were getting care. The one doc that would come in 24 hours a day, 7 days a week for their patients. Thankfully, professionally, that doesn't happen anymore. But I think that my guess is that's the reason for the redesign is care is now broken up between a number of providers where in the past it was not. But I don't know. I thought it was state by state, but I'll ask John when I see him in a couple of weeks. Well, we've kept you long enough. It's such a pleasure to see you.
Me too. Thank you for having me. I appreciate it.
Yeah. Well, no, it's a pleasure to see you. I'm excited to see you in person. Your commute's going to be much shorter than mine to Vancouver.
I get to drive to this one. It's very exciting.
For which I'm very jealous. But I look forward to seeing you, Amy. Always good to have you do this with us. And we'll see you guys soon.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess,
and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.